Hi, well thank you very much for the invite, and I'm going to talk today sort of very similar themes to Tom. We're both surgeons, so you're going to get much more of a surgical flavour from me as well. What I'm going to talk about is what we've set up. So Oxford and NSIC is the National Spinal Injury Centre, which is at Stoke Mandeville in Aylesbury, and we've been working together on this to try and help. We've seen predominantly kids with AFP and Reconstruction. So this is what I'm going to talk about. I'm going to talk about who we are. I'm going to talk about how the service developed, and then I'm going to talk about things that I knew that the group here was very much patient or parent focused, so this is very much aimed for you guys. I'm going to try and talk to you about what happens when you see us and what happens, and I'm going to sort of base it on the questions that I've normally been asked. So first assessment: who do I see, when and where? What do I tell parents about kids with AFP, and what do we know so far? What are the operations available? What is the perioperative care for the patients that have in some of these operations? What happens after that, so rehab, and also what's next for the service and for our patients. So a couple of things just to remember. The first thing is I'm acutely aware that this group is a small group and that a lot of you know each other from social media groups. So I'm going to give very, very little detail about specific cases that I've had, because I've got a responsibility to the family's privacy, and I can't breach their confidentiality. The other thing to remember is, and it's been said all morning, is each child is totally individual. So what I'm going to talk about is the ethos about what we're doing and about the care, rather than very specific points, because each one of you, if I saw you, I'd be telling you slightly different things, but the general points are there. So who am I? I'm a plastic surgeon, so slightly different from Tom, but we tend to cross over on various things. I trained in Yorkshire. This is me many years ago with a guy called Simon Kay, who you may know because he's done the first hand transplant. So he's more famous in this country for that now, but actually the majority of his career is been largely children's hand focused. And he's a fantastic surgeon, and working with him, I think, gave me certainly a much, much better insight into the care of children with complex problems, in that every child's individual for sure, but we've got to think of the parents, we've got to think of the psychology, we've got to think of the aesthetics, not just the function. So it's not all about operating, it's about going through this journey together over a long period of time, because with children you're normally following them up till they're 18 and looking after all aspects of that child's care. Having completed my registrar training in Yorkshire, I then went and did special training in Melbourne. So this is the Royal Children's Hospital, which is, for any of you with any interest in children's surgery, is just amazing, and I would go and just see what they're doing there. The facilities are just wonderful. I did lots of microsurgery, so that's looking under a microscope, usually suturing small vessels or small nerves together. Lots of nerve surgery, lots of children's hand surgery, and also some adult hand surgery as well. So what do I do now? I'm 5 years in as a consultant. I work at the Oxford John Radcliffe Hospital. It's I think it's got an excellent reputation and has done for a very long time for children's and adult hand work. I've got 3 senior colleagues who are about 10 years older than me. And they've got a massive wealth of experience in nerve surgery, children's, adults, complex surgery. I'm also a member of the major trauma orthoplastics team. I work with a lot of people of orthopaedic nature. We fix all the open lower legs. We do lots of complex upper and lower limb reconstructive surgery for both children and adults. And in addition to that, I'm the clinical governance lead, which means that I try and make sure our department is as safety orientated and as careful as possible. These are the guys I've been working with. So this is the National Spinal Injuries Unit. It first started in 1944, and it's the oldest continuously running spinal injuries unit in the country. This is a picture of it in 1954, and you can see it's changed quite a lot. It's much more modern now. They obviously look after adults as well, but what they have got is a 9-bedded exclusive children's ward for children up to the age of 18, and that's been there now. Well, they've been seeing children from the 50s, but it's had this special ward for about 15 years, I think. They have got what they call CARF accreditation for paediatric service. So what that means, it's a peer-reviewed independent evaluation of the services, specifically looking at their rehabilitation facilities and setup. And outside of North America, they're the only unit apparently that have got this. So they're very good. And having been there and not worked there before, I've been completely blown away by the setup and what they've got there, and I think it's a wonderful, wonderful resource. So they accept children from all over the UK, and Alison Graham, who unfortunately can't be here today, she's not feeling very well, she's the consultant that looks after all the children for the spinal injuries. She's also the lead now for the spinal injuries. And Naomi, can you put your hand up? There, she's at the back. Naomi and I have got to know each other really quite well over the last year. She's a very specialised occupational therapist who has worked with all of the AFP kids that we've seen and that I've operated on. She's adapted a lot of techniques that she already knew for to look after these kids, and she's just absolutely cracked on and done it. And I can tell you, she does amazing customised individual rehab programs for every single child. And no, she's putting her head down now, but you know, it's real dedication. So this is who we are. How did it develop? Well, as I think a lot of you have pointed out, some of these children, when they are first diagnosed, they've got multiple limbs involved, and after they've had the acute stuff investigated and treated, they'll get sent for rehab first to certain places, and some of them have been coming to the spinal injuries unit with usually multiple limb paralysis. So at this point there's usually a diagnosis already made. They've already had any acute treatment that was possible, and they then get admitted for a period of assessment and help with rehabilitation. And it was recognised by the guys there that there was a lot of these kids that were not getting completely better. Some were getting better, maybe one of the limbs got completely better, but then one of the limbs didn't. And there is a plastic surgery team there, and they had a chat with them and said, look, you know, what do you think? Is there anything we can do? Those plastic surgeons are very good friends of mine, and they said, look, you know, we don't do this sort of thing, but we know someone that does. And this sort of surgery is complex surgery that's not done by very many people in the UK, especially in children as young as 2. So it narrows it down quite a lot. And I heard about it and I was thinking, well, you know, we should try and do something. This is what I've been trained to deal with. In the background, there was this guy called Mitch Sharuya, who is they call them attending in America, I think, but he's a consultant. Is that right? Yeah. He's an attending. Sounds much cooler, doesn't it? He's a consultant, he's a plastic surgeon, and he's predominantly nerve focused and children's hands focused in Los Angeles. The reason this is kind of relevant is because, you know, we actually met when we were on fellowship together in Melbourne. So he was there doing a head and neck thing, and I was doing the limb thing, and we got friends, and then he stayed on and did the limb fellowship that I'd done. And we stayed in contact on Facebook, and I could see all these things coming through on his Facebook page about how he treated these kids and some wonderful feedback from the parents. So I reached out to him and said, look, this is the situation, there's kids here that have got this problem, you know, what can I do to help? And after several emails and conversations via Skype and things, you know, I think we sort of got to the point where you know, I thought that there was something that I could do. So he's treated probably over 50 patients, he's operated on over half of those, and he's seen them at various points. So as we've mentioned today, the pickup has often not been very good years ago. So some children were seeing him 2-3 years down the line, and then more recently he's been seeing them more regularly, more early in their process. So what he was able to do is follow a lot of these kids up and see what was improving, what wasn't. And also talk to me about the operations that he's done and what his outcomes were. Now he's probably about to publish that this year, but that was information he was happy to share with me. By spring 2019, there was 2 patients that I thought would be good candidates for surgery, and had been discussed it with Mitch and some of my senior colleagues at Oxford. We all agreed that we thought it was worth doing, and the families were keen for that too. I then had to really organise quite a quick level, because we were quite far down their pathway by that point, the operations and the funding, and was very lucky because Mitch offered to come over. And I managed to get some charitable funding from the Oxford Hospitals Trust, and he came over for a week. He did a really good talk to the medical staff, the rehab staff, and he was with me for the surgeries. He didn't operate, but he was in theatre with me. We'd gone through plans and was able to really give me a lot of instant feedback in surgery, tips and tricks. You could just ask him things that you just don't get unless they're there with you. So we've now done 3 surgeries. We've got 1 more planned, and that's kind of where we're up to at the moment. So in terms of the first assessment, who would I see? I'd see anyone. I mean, this is a rare condition. I think people have a lot of questions and they've maybe been told different things. And if you just want to come and have a chat, just to sense check whether there is anything you can do or not do, I'm more than happy to see you. Most of the people that have come to see me have obviously sought out seeing a surgeon. They've obviously thought about it, done a lot of research. You're quite an educated, people within this group have done their research themselves, and they've kind of already thought, I think this might work. So they've contacted us with a view to at least considering surgery. When would I see them? Ideally as soon as possible, and I think some of the earlier talks about, getting this notifiable and getting the diagnosis earlier would be great. I think most of us are not seeing the kids till they're at least 9 months, which then, you're already quite a long way down the line. But ideally by 3 months would be great, and then you can repeatedly see them and re-examine them and see what improvement they've had. It also, if they're referred to the National Spinal Injury Centre first, or at least to somewhere that does a lot of rehab, you're already starting the rehab for the muscles that do work, which is really important. So ideally, we'd at least have decided on surgery by a year. So where do we see them? That first assessment is done by myself, Naomi and Alison. It may take multiple appointments, and I think what I've really realised just in the small number of people that I've seen is this is a very traumatic event. By the time I've seen you, from the point of view of the child, they've perhaps gone through multiple medical admissions, multiple tests, some of which are painful. They are traumatised, they are scared, and they don't always want you to examine them. They're also very young, like between 2 and 4, and having got a 2.5-year-old myself, I mean, just sometimes getting him to put a sock on is in itself like a major challenge. So actually doing a full examination can be difficult. It's also good for me to kind of get a sense check from the parents, from the parents as to how they're coping, what stuff they've got in place already. Have they got community support? Have they got some physio and rehab? How are they coping? And what are their thoughts? And it may be that we have to see each other a couple of times before I get really what is a decent level of examination from the child. And the other thing is, obviously, we need to know generalised health, and if there's still seen other specialities, if they've got any other medical problems that are still going to be relevant to any surgery. So this is the sort of examination sheet. Having sat at the back, I know that most of you won't be able to see it, but it's basically, we're looking at multiple muscle movements. In young children, you can't really assess strength, so you're looking more at the movement, and these are really related to the full range of movement. So, you know, the full range of movement of biceps would be from straight all the way up to the top. And you're factoring into that whether they can move against gravity or not. So if you can't move against gravity, that means you're at the weaker end. If you can move against gravity at least some way, then you're a bit better. And if you can move against gravity all the way, then you're pretty normal. And again, some of these change and some of them don't. And we track those charts and we sort of keep looking at them. So what do I tell parents about what we know so far and what we're going to do? This is Mitch's little thing that he told me. I think it's incredibly complex stuff to understand. I think even if you're medical, it's hard to understand. So for someone with no medical background to kind of get to grips with this stuff is, you know, hats off to you completely. When I was trying to get to grips with it, just trying to get the concept in my mind, I sort of thought of it more as like almost like an inflammatory thing, like a brachiitis type picture in terms of the clinical picture that we see. But he was like, no, it's more like what we would class more as, I suppose, sort of as like a almost like a convulsion in type injury in the pattern that we see. In that it's like the switch goes off and everything stops. And a lot of you, when you come to see me and you describe that first few days, it's like that they go from being completely normal and then next minute it's gone. So this is a fairly simple diagram about how a nerve makes a muscle work. So to start off, you need a spinal cord. And then within the spinal cord, there's these things that you all know now, anterior horn cells. That's where the motor starts in here. It kind of grows out into a little root, which looks like a plant root, comes out through the spinal cord, the spinal column, sort of into the neck or the back or whatever. And the nerve root then becomes a peripheral nerve, which is just a nerve. It travels all the way down to whichever muscle it's going to do. So for instance, if I was thinking about the nerve to my bicep, it comes out of my neck as a nerve root, it travels down my arm, hits my bicep. When it hits the bicep, it's actually hitting a little neuromuscular junction, and that is like a little switch, and when the nerve stimulates and it hits it, the muscle contracts. So a muscle that is usually sort of either side of some joint, so you know my biceps is up in my shoulder and then in my forearm. When it contracts, it makes it squeeze and you bring it in. Conversely, the triceps, which is at the back, when that works, it opens it up, so you flex in an extension. If there is any break in that pathway, the nerve, it stops. So whether the muscle gets trashed and takes out the neuromuscular junction, that wouldn't work. If the peripheral nerve gets cut, that wouldn't work. If the nerve root gets pulled out, or if the spinal cord gets injured, then it goes down. This is where it gets even more complex, because the supply of an upper limb or a lower limb is incredibly complex. So you can see here, this is an upper limb. You've got the spinal cord, you've got roots coming out, making nerves which go into the arm. Each nerve supplies a muscle or muscle group. There's 5 major nerves that supply the upper limb, and each one is kind of getting a communication from the spine. So for instance, you know, C5 is mainly the shoulder, whereas T1 is mainly the hand. And any sort of connection in that is going to cause a loss of power or dystole. So Tom and I have talked about the fact that we're much more used to treating traumatic injuries, and that gives a very definite pattern. You can, from examination, pinpoint almost exactly where that nerve has been injured. This is much more unpredictable, I think, and from doing the surgery I've found that I've seen a nerve which has basically come from the same thing. It's split into 2, and just before it's gone into the muscle, one bit worked and one bit didn't, which is, you know, just I think interesting for us as a group. Okie doke. So what are the observations of myself and Mitch? Generally more than one limb is involved, which we've seen as well from the other talks this morning. If you have non-limb involvement, so if you've been, you know, affected respiratory-wise or facial palsy or whatever, tends to be more severe, I think. More than probably 80% will not recover at least M3 function. That means anti-gravity, so against gravity. That may not be the whole limb, it may just be that, one particular muscle group, but there will be often some residual weakness there. What Mitch has looked at is, from all of his group, is he's plotted what their recovery was, whether, when they didn't have before surgery. And he found that if they were sort of getting to 3 to 6 months, and they didn't have a good degree of function in that particular nerve, then they were unlikely to improve in that over time. And that's been what we've seen. We've seen that some of the muscles that were weak, but there was something there, have got better. Whereas there was some muscle groups that just literally have had nothing, and they've not improved at all, like just completely. The shoulder area tends to be more affected than the hand, and often the nerves we use for transfer are also affected and can't be used. So some of the common nerve transfers that we have done for brachial plexus surgery, like the spinal accessory nerve to the shoulder, one of the shoulder nerves, so that's a nerve that makes the trapezius muscle at the back move. Mitch has found that 90% in the cases are not working. So one of the key nerve transfers that we would have used is not working. And often there are multiple things that don't. And also we've talked about today some postural instability, and again that's something that we've seen as well within the group, and particularly with Mitch's group. So each child is unique, no child's the same. The overall sort of personality of the child, what they like, what they don't like, really kind of directs us to a lot of the rehab and to what we can do. The pattern of weakness is variable, the degree of improvement is variable, and so therefore the priority of the reconstruction is variable. So as everyone said, there's no one prescription for everyone. And the problems related to the reconstructions are unique as well, so the particular issues around each child. Nerve transfers, so Tom went through it, and I felt like I understood it really well, hopefully you did. But just to go through again, so this is our picture that we've looked at earlier. We know with big cross, the anterior horn root's not working. So this whole nerve is not working, and the muscle is not working, okay? Because it's so proximal, we can't get above it. If I was to cut this nerve here, I could just repair it. If a section of the nerve was damaged, we could repair it, put a nerve graft in. However, when it's so high, when it's at nerve root level, so it's been like pulled out of the spine or within this particular area, it is too high to bridge the gap. So really you have to take a nerve from somewhere else. So this is a normal nerve from a different part of the spinal cord that's not affected. We track it down, we decide, that's the one we're going to take. We cut it as close, at the point that we need it. That muscle no longer then works. And then we thread it across to as close to the neuromuscular junction, as close to the muscle as we can on the muscle that we want to, the recipient muscle, and we suture it in. And then what happens is gradually over time, the nerve fibres are sort of growing this way and then into the muscle. So when this stimulates, it will then go like that. What we're seeing here is that this takes away that sort of initial problem. So would this operation work for my child? This is, I guess, what you guys probably want to know is, so first of all, is there a target muscle? Is there a weak muscle? There may be multiple muscles. That weak muscle is what we call the sort of recipient, really. That we then want to see, is there an available nerve to donate? So in general, what we want is a nerve that's close to the muscle. So if I've got a weak muscle here in my arm, I can't take it from my leg. It has to be something that's reasonably in the same vicinity. The muscle that we are going to lose is got to be dispensable. So, for instance, intercostal nerves, we've got long history in plexus reconstruction of using intercostal nerves. You can cope without some. Another example, for instance, triceps. It's got 3 heads, it's got 3 nerves going to it. It's a well-known nerve transfer that you just take one of those nerves, one of those heads, and you can put it into another muscle, and the triceps itself may be a little bit weakened, but for most people it's not an issue. So the third thing is that nerve or muscle really needs to be normal strength. There's no point taking a damaged nerve already, because you will always lose a bit. So if you've already taken a damaged nerve, then by the time it reinnervates the new one, it's going to be even weaker. So it has to be normal or very, very close to normal. And then the last thing is it needs to be something that's going to be retrainable. So you can't do something that's kind of contradicts. You can't use something that's going to contradict almost the function of that new muscle. The next thing is the muscle receptor that we've talked about. And that is a concept that traditionally there's been a thought process that it will kind of wither away if it's not stimulated. And I think we all still believe that is true. However, there is a thought process that seems to be less relevant with this group. And I mean, that's already been talked about today, so I won't dwell on it. But, you know, why that is, not 100% sure. Maybe because the sensation's intact. I know that Mitch has done cases over sort of 20 months. And, you know, we'll wait to see what the results are. But I think I wouldn't want to say to you today, I won't do anyone over this amount of time. I think it's all on an individual basis. And they have to be well enough for surgery. I mean, you know, some kids don't recover as well, and it would be not advisable to do operations as complex as this and as long as this in some of those kids. So it really depends kind of what their overall sort of level of fitness is, etc. The last thing is, if you've got multiple muscles that need reconstruction, then you're going to need to prioritise. You know, there is a limit. The truth is that people that I've seen have often got more weak muscles than there are donors. So you kind of have to prioritise and say, well, what are we going to do? And it may be that you can't do everything, or it may be that you can do some and then you maybe do a tendon transfer or something a bit later. But that is an issue, and it's something to just think about when you're planning at the beginning. So expected outcomes.
Can I just ask you a question on that?
Yeah, you can.
A few of us where our kids are affected in the upper limbs, the arm isn't working. So presumably then if you had an unlimited number of nerves that you could transfer, theoretically, presumably you need to transfer them to every part of the arm that needs that muscle to be stimulated. So is it really possible to get a whole arm working, and then presumably not, so you'd need to sort of focus on one muscle only, or one function,
yeah.
And then if you did that, which part of the arm would you effectively go after? Is it the hand or the forearm or the upper arm?
Yeah. So in those kids where there's literally nothing, then the intercostal nerves are really the main option for doing that. And although there is multiple intercostal nerves, they're a lot smaller than the nerves in the main nerves in the arm. So you have to do like a group of them, like 2 of them or 3 of them. And you have to pick which ones you're going to do. You know, traditionally we've favoured the shoulder first and the elbow, so that you've got kind of some degree of posture in the shoulder and that you can pick something up, even though the hand doesn't work. If there is, you know, but then if the hand doesn't work either, then that's also another big priority, because of, you know, even if you can sort of move it, if you can't pick anything up, you're probably not going to use it. So this is what it comes back to, that there is sometimes something, and the intercostals do offer an option, but it's hard to say without seeing each child individually and kind of doing a full assessment and that. But yeah, the children I've seen have been at, I think, the more severe end of the spectrum, because of the way that the nature of the referrals that have come to me, and we've managed to do something. But you know, there is times, I guess, when there is no reconstructible option, but at least it's worth at least having that discussion, I think. The problem is with the outcomes is that it takes quite a long time. It can take 2, even more years before you're seeing stuff. And it's frustrating, I guess, and it's difficult for people when we're talking about this. So I can't tell you my outcomes because my first operation was 6 months ago. So I'm not expecting them to be fully at their full limits by now. What I can tell you is that we've done 3 surgeries and we've got 1 more. And the 3 that we did, there was no major complications. We worked very, very hard to be as safe as possible. One of the reasons for getting Mitch over is because I thought it was the safest thing to do. We also liaised with the anaesthetist at the Children's Hospital, and the anaesthetist spoke to them directly, and we used the same anaesthetic protocols that they did. They were not they were sort of anaesthetised in a way specific for this group of children, and we used the same. We've adapted the protocols that they've used there as well. So, yeah, we've done everything we can to be as safe as possible, and we so far have not got any major problems, and I'm quite happy with the results that I'm seeing so far. From the American data, obviously I've got Mitch's, you'll all have that soon. Philadelphia have just published quite a big series, sort of October, November. And the positive thing is that it suggests that these nerve transfers do work. You know, they're getting good results. The time limit, as I said, seems to be less important. So, you know, there is some positive news, I think. The shoulder, what they've found is that certainly the posture is better. So some of the kids who've got a completely flail have got a sort of shoulder that dips down, sort of pseudo subluxation. That seems to improve in all of them. In terms of the movement, this sort of movement seems to do very well. That sort of movement, less well. It can get up to usually about this level. The way that the shoulder is, in terms of what we talk about, the outcomes measures, the shoulder outcome measure is sort of quite complex because it's a kind of multi-axial joint. And although some of the results would say that that's not brilliant, I actually think that if you've got this, this and this, you've got quite a functional shoulder. Because if you go home tonight and do a few things for a few hours and think about what your arm's doing, most of the things that you're doing are not up here. I'm on my laptop, you know, I'm going forward with my shoulder, reaching out for a coffee. I'm sort of got a bit of, I'm only going up to about 90. I'm sort of using my external, internal rotation and my elbow. So I think that even though perhaps someone would say that that's not a brilliant outcome to not get any higher than that, I still think that it's better than nothing. Elbow flexion is good. So the results from it, if you're having a transfer for elbow flexion, the results for that are usually good. They're sort of getting essentially not normal, but they're getting full range of movement against gravity in a lot of them. Slightly less so for the extension, but it's the results are good or excellent in a big proportion of them. They have less hand-affected patients. They only have 1 patient in the Philadelphia study. They did a much more local nerve transfer, which suggests to me that the patient had a sort of better overall limb, and they got an excellent result. Mitch has done a few now where they've had a more like a complete flail arm, and he's done intercostal nerves to the median nerve, and they've been getting at least anti-gravity, so they're able to flex in. I would say his feedback to me was he's not had a patient or a parent that said they're not glad they didn't do it, because when you start with very little, anything's an improvement, and I think that's probably the key, is that at least it's something. But yeah, certainly some of these nerve transfers have got good results. Why are the results in some individuals worse? So some in the Philadelphia paper didn't get brilliant results, and especially in the shoulder. I think it's complex. I think it could be because of the outcome, the way that we've talked about the outcomes. It could be because the shoulder is a sort of multi-axial thing. You know, biceps is just doing this, whereas, you know, some of the muscles in the shoulder are doing multiple things. It could be because, you know, the virus affects the shoulder area more. It could be because they've used a nerve in the area that they thought was okay, but actually it was more affected than they thought. Not sure. Another mystery. Perioperative care. So having seen us maybe once, maybe multiple times at the spinal injury centre, you come in to see me the day before, we get photos, we re-examine you. We're now getting custom-made splinters from Stoke so that I put them on in theatre. If you're having something like an intercostal nerve transfer, you're probably going to be in for about 4 days. It will be at the John Radcliffe. One of our patients went to HDU, which was completely precautionary when we first started, but we soon realised that they didn't need it, and they just go to a normal ward with a side room and a specialised, sort of a nurse that's like more one-on-one. The operation time's variable, so depending on what nerve transfer we're doing, if they're having intercostal nerves, it's going to be all day. They have drains in. They have a little pain catheter thing that the nurses press for them, and they have a urinary catheter in for about 24 hours. I've been absolutely shocked at the sort of low levels of pain that they've got. I mean, within 24 hours, the PCA comes down and they're onto normal pain meds. And the thing that they've been most bothered about is kind of, I think, the long lie and the kind of the shoulder being in this position for such a long time while I've operated. But the actual pain from the cuts and stuff, they just don't seem to be really that fazed by. They then go home in a sling if they've got the intercostal nerves. It's really stuck down, and we see them at 2 weeks for a dressing change. That is mostly just done with a bit of pain relief and gentle coaxing. There was one child that literally wouldn't let us go anywhere near, so we had to do a brief general anaesthetic. And then what we do is we give the instructions for you to go home with for the first 12 weeks. So Naomi has done a little booklet with instructions and photos in it, so that when you go home, because often people don't live anywhere near the unit. The reason for the intercostal for the sling in particular with the intercostal nerves is because when you take an intercostal nerve, you're taking it, sort of cutting it here, it comes round, you're raising it all the way up, so it's then here, and then you're plugging it into the arm somewhere. So what you don't want is the child to be doing that. Not that they often can do that anyway, but you just don't want them to be going a bit, crazy. Sorry.
In the lower limb transfers that we've done, one of the joys of nerve transfer is you can get these things quite lax, quite loose. As we mentioned, tension you don't want because it will pull apart. Kids with lower limb paralysis are often wheelchair bound anyway. Sorry, who asked them? Sorry, yeah. Wheelchair bound anyway. So if we're doing transfers, you don't really want them sitting on it, particularly if they've got wasted gluteus and everything else. So it's about having load sharing, but you've got to put it lax because you've got to recognise the child's got to be nappy changed, moved around. It is, don't spin the child around by the leg, but you really can't immobilise these things. And then again with the upper limb transfers, it's just about making sure that you can continue the rehab. Around the fact that you've got to do these, it's sort of the payoff between the tension of your repair, as Sara's saying, and then what you can do in terms of continuing rehab. But you can't put the lower limb in a sling.
No, I just wondered how that would work. I mean, compared to.
So in essence, the transgluteal transfers that I've done, it's just making sure that we've got a padded load sharing thing for the wheelchair, so you're not just sat on your bony bum, and then just making sure that if you're going to flex the hip, you're bending the knee, so you're not stretching it. So just some simple advice for the parents.
Right.
What happens next? Rehab, fun with a 3-year-old. Both you're probably going to have some muscles that are working but weak, and then you've got the newly operated ones. So we need to continue working on the weak ones, but then we also need to be kind of now giving you a very specific program for the newly operated on ones. So they have this immobilisation phase, which is sort of between 0 and 12 weeks. So they're doing passive exercises, and you're gradually cranking them out so they get back to full range of movement. They then start this thing called the early re-innovation stage. So they're admitted at week 12 to Stoke for a week. We reassess them, make sure that they're okay. If there's any problems, the passive range of movements come back. Do they need any change in splints or whatever? And we kind of educate you on what to look for. So you'll start to see little twitches and things like that. So it's trying to help you look for those specific things. And then what things you need to do to try and encourage the little twitches to become more. Sort of fast forward several months, and sort of normally between sort of about 6 months and 12 months. This is very dependent on the length of like how far the nerve transfer is from the original nerve. So if it's very close, it will be sooner. If it's further away, it will be longer. So then you want to start on the gravity eliminated phase. So we've talked about today that these muscles are weak and that they get tired very quickly. If what we need to do is take the gravity away from the movement, so it's better that they're doing some movements but with the gravity eliminated rather than nothing, because they can't do anything. So lots of hydrotherapy, lots of anti-gravity stuff. So for instance with biceps, rather than be doing this, you want it to be doing this, so it's anti-gravity. So we're trying to make it into a game so that the kids are going to do it. There's also anti-gravity type equipment. Some of you have got these robotic arm type things that seem pretty cool. Anything to try and help with that phase, and that's probably the sort of the longest phase, because it will overlap with the sort of early reinnervation often. Then after a sort of certain period of time, you'll start to get movement against gravity, and you build that up. So you start to sort of increase the amount of movements that you're doing in the gravity, and that goes on for a period of time, and it can be between about 12 and 18 months. And then once you start to get to a much stronger sort of point, you're then actually trying to build up the muscle strength and the function, and you're doing that by building it up with weights and sort of integrating it into sort of more fun activities. And during this time, places like this, with the fairs, fantastic, any resource you can. We try and liaise with the community physios. We try and help with trying to get some hydrotherapy. Each child likes slightly different things. Some might like doing little arts and crafty things, some like to do various things. Whatever you can do to get them to do their stuff is good. And this is just kind of reiterating what we've just talked about in terms of the phases of a nerve transfer. So very early on, not much, a bit frustrating for you guys, but then when you do start to see the twitch and a little bit of movement, it's really exciting. And then, more hard work continues, trying to build up, doing all the exercises with the kids. What's the future? Well, for the kids, it's a very long journey, isn't it? They're going to be doing lots of this, lots of weights, lots of physio. The surgery is the scary bit, but it's over so quickly. It's really over, in a blink of an eye compared to the journey that you've got in terms of the rehab. And you're going to be seeing us for a very long time. We're talking like years here. But I think it's something positive, and at least it's something that I think most people feel they can sink their teeth into and get going with. I don't know how many more patients we'll see. I guess it will depend on how many, will the referral rates go up once people start identifying people that need it more. If those numbers that we looked at today are the case, we need to really sort of think, because 66 people a year, 66 people within 2 years would absolutely drown us, even if there was 2 or 3 of us in the country doing it, because each case is a lot of work. So probably formalising the service. We've talked a lot about outcomes. We're keeping our outcomes, we're documenting them each time we see the patients, and when it gets to the point that I've got data to show, I will present this at meetings and journals, which is what we do. And the parents sort of know that that's happening. So thank you. I just want to thank a couple of people. Alison, who can't be here, Naomi, who I've already kind of thanked, our anaesthetist, who totally went the extra mile, and all the nurses. The last patient, it was in the middle of what we had a code black in the country where there was no paediatric beds at all, but we still managed to get that done, and that was because people, I think really want to help children with this sort of thing. I'd like to thank Mitch, who's been completely unselfish. He's done nothing but be supportive and try and help me sort of develop the service for patients in the UK. And finally, I'd like to thank the kids and the families who put their trust in us as a group and decided to go for it. So thank you.
Everybody afternoon is just I'm going to go on.
Yeah, everyone's asleep now.
I'm going to wake you up.
I've got a question. Okay, so would you, I mean, obviously every case is different, but for a child that's got paralysis in the arm and also one side of the diaphragm, and you're taking nerves from the intercostal muscles, would you want to do that with a child who's got respiratory problems as well? And I suppose you've only done a few cases, I suppose. What do you think of that? And can you take it from the other side if it's only one side of paralysis from the diaphragm? Can you do that?
Yeah, great question. We've all got a line in the sand that we're happy to go, and that's probably a line I wouldn't go over. So there's been an argument for a very, very long time about if you are taking intercostal nerves, whether you can take phrenic nerves as well. That's been predominantly in the traumatic brachial plexus type of injuries that Tom and I have been treating. In Asia, they do that. They'll take the phrenic nerves, they'll take the intercostals, and the reports for like 10 years down the line are that they seem to be okay. Mitch in America will take the phrenic nerve as well as a donor. He works with the thoracic surgeons. They take it endoscopically and they use that to function another group of muscles that aren't working in a full, basically flail arm. I've got concerns. I think that we're not, and I've spoken to Alison Graham a lot about this, because obviously we're all slightly adapting what we do normally, and Alison has got a wealth of experience in spinal injuries, and these are children, they're not adults, and what her main concern is yes, obviously we'd be concerned that there'd be an immediate problem with respiration, although Mitch tells me that has not been the case. But my concern is more what they would be like over time. So would the growth of the chest, the respiratory function of that child over time be normal? Because first, do no harm. I mean, number one, thank God the kids are alive. Number two, yeah, they've got a flail arm or a flail leg, but they're still going to probably have a happy life. What we don't want to do is to do something that makes them worse. So what I don't want is that, yeah, they're all right at the beginning, but like by age 30, they've got like basically a poorly functioning chest, and that's because of it. So I wouldn't take the phrenic either as a donor, and if the phrenic didn't work, I don't think I'd do nerve transfers from the intercostals.
So we had slight breathing problems in the beginning, but he was off the ventilator within 6 weeks and he was fine. But that was one of the main reasons why we didn't even consider. We were at the John Radcliffe actually in 2016, so it wasn't even entertained then. So, interestingly, at the nerve transfer day, there was a gentleman that his nerve transfer hadn't worked, but his muscle transfer had worked to treat. So that is kind of something we're thinking of as an option. So would that be possible? How does the muscle transfer work if the nerve one doesn't? I'm not quite au fait with that.
So it's just very briefly, it's that waiting time. So if you're taking a new muscle, so you're doing a free functioning muscle transfer, that is newly de-innervated. So that's a muscle that was working, that's all of a sudden had to start waiting at the train station again. Yeah. So you can get nerves to that well within its re-innervation time. So you do a nerve transfer onto a free functioning muscle. That's not muscle that was de-innervated originally. It's brand new waiting time.
But you would still need a working nerve.
You've still got to have a nerve. So
yeah.
It needs a locally. That's not a problem. In this condition, it's actually lovely, easy dissection because the arm itself isn't traumatised. So there's no problem getting the blood in and out, but there still needs to be linked to the brain.
Yeah.
And you can't take the nerve with it, as it were, because it's got to go down the spinal cord and out the spinal cord to the leg, and you can't unwrap that up to the spinal cord to come out the arm. So yes, so it's still.
So you need the nerves,
a nerve,
and then you've got to decide which path is the best. Yeah. If you've got it,
and where you put the muscle and how it works, and what the skin does, and all those other challenges.
So they have talked about tendon transfer as well, just to get a bit more action in the hand. So that I presume is quite local and quite simpler.
It's just cutting a cord,
Yeah.
and when the muscle contracts, instead of pulling this bit down, it pulls that bit down. And it's as simple as that. And it's what we've done and our people like us have done for hundreds and hundreds of years. And it's where in polio, particularly in India, where they still have endemic cases of polio, the experience there, we've learned a lot from in paralysis generally. So tendon transfer is well understood and reliable. And if it's possible, it's much better because it gives you a result quicker and more reliable than a nerve transfer. So we don't often have those options. And often, if there's bits and pieces, we'll do things together. It's very common that we will do nerve transfers, tendon transfers, fusions as part of a package of care.
Yeah, I totally agree.
Yeah,
I totally agree with that. And I mean, I don't know if I'd say that I think tendon transfers are better than nerve, but because I think in some situations, nerve transfers are really good. But then in other situations, the tendon transfers, you know, are great and always have been. And for that particular deformity, you would probably still go with a tendon transfer because there's no nerve transfer that does it better. Each thing's different. I think the thing is that you need, if someone's offering it, there needs to be something good there working, whether it's a nerve or whether it's the muscle. You know, by definition, if a tendon or if a muscle's working, there's a good nerve nearby. It's just, is there something there? You know.
We have been given those options at Stoke, so it's just nice to know because everyone talks about nerve transfer because that's the hot topic at the moment, obviously. But there are other things there, like the muscle and the tendon transfers, and people don't.
Yeah, for sure. No. I think when we see, and I'm sure Tom's the same, we're like not just thinking of that. We're thinking of the whole big picture. And actually, maybe sometimes I'm thinking with some of the kids that I've done, right, I'm going to do this as a nerve transfer, but then if that's, you know, I can potentially do that later, the tendon transfer, because tendon transfers are not time dependent, whereas nerve are.
And the only thing we can't easily do in kids is joint fusions because the bones are growing. Fusing bones causes all sorts of trouble. In adults, it's often a good option to stop a shoulder that's dropping out of joint, just fuse it together. So there's options, and there are options like tendon transfer that can be done at any time. But you would never be fusing a joint in a child during growth unless it was really exceptional, treating infection or something where it was already a problem.
But once they stop growing, then it's just too risky while they're still growing.
Well, it's not risky. In fact, it's probably easier to get a bone to heal in a kid because they're very good at healing breaks. It's just the growth plate's always around the joints, and so trying to get them fused and the problems of fusion are more challenging. But you can always do it later, so you just plan. We can do that later. So it's one option we don't tend to use as much. You sometimes tighten capsules and joints around joints, but actually making the bones join as one, a fusion, tend not to do that in kids, whereas all the other options are open.
So your specialty is hand and arm. It sounds like I've got a dorsiflexion issue in the foot, and then so you mentioned time barred about the nerve transfer. How would one know the receptor? How do you know that receptor is switched off? That even if you were coming from a weak place to transfer to get the signal to it, how would you know that it was sort of a?
You can do some of the electrophysiology tests, which can help. You know, it's hard to give you a definite answer, but you can do sort of, you know, the nerve conduction test we've talked about can be helpful. Yeah. I do lower limb as well. I'm not just, I know my title on my thing is hand, but I do all limbs, all four limbs.